All right, this is pancreatic disease. This doesn't have any of the questions for mix-up in it, but if you want to pursue active learning, do these mix-up questions, and then as you complete the questions, you can then go back and watch these videos to fill in any knowledge gaps that you may need. So to start, we'll start with off. Please pause and do mix-up 19, GI question 12. And really this goes into, this is my one slide for really management diagnosis of acute pancreatitis. So going over diagnosis of acute pancreatitis really relies on two out of three things. So the one thing you're going to need is that typical pain, right? So typical acute pancreatitis pain is going to be acute. It's going to be epigastric pain. There may be some radiation to the back, and it most commonly is going to be worsened by food and may be worsened by laying back and improved a little bit with sitting up, but not always. I don't know the exact sensitivity or specificity of that last finding. So typical pancreatitis pain, which we went over. 2 would be lipase, but your lipase is going to have to be greater than 3 times upper limit normal. Now, if you have a patient who comes to the hospital and they have all these manifestations and you have a high probability for acute pancreatitis, boom, you just made the diagnosis with 2 out of 3. Now, it gets a little bit more difficult when, let's say, the patient comes in with very typical pain or no pain and a severely elevated lipase. In those cases, you still can't perfectly make the diagnosis. And in those cases, when there is some diagnostic confusion, those patients you can check a CT scan. And a CT scan in general, with IV contrast, is going to be looking for signs and symptoms of acute inflammation. So here's your pancreas right here. Should have used red. And you can kind of see that there's some haziness, fat stranding around the pancreas. Here's your splenic vein right here, but that fat stranding is significant for inflammation of the pancreas as well. So you don't need the CT scan routinely, but if you cannot make the diagnosis by having 2 out of the other 3 signs and symptoms, then that's the time in which you would pursue a CT scan. So then it gets into what is the workup for acute pancreatitis. And for this, I think it's probably best, there we go, to go into the causes of acute pancreatitis. So commonly taught a lot of different causes of pancreatitis, and you're given mnemonics, which I don't really think are helpful. So I think the best thing to know about the pancreas is just the most common causes, the ones that we really always work up. Number 1 and 2 are going to be biliary disease and alcohol. Now these cause most commonly, the most common cause of pancreatitis and causes really the majority of pancreatitis. Alcohol causes direct toxicity to the pancreas, to the pancreatic exocrine cells, causing acute pancreatitis. And biliary there is a little bit of more knowledge to know about this. So here's your biliary system here, common bile duct going down through the pancreas, and then you kind of have your pancreatic duct meeting it before those both empty into the duodenum. What happens here is these patients usually just have small gallstones, and that small gallstone subsequently goes down your common bile duct and gets stuck right at the pancreatic head. But usually it really only gets stuck momentarily, and when it gets stuck momentarily, there's a back pressure into the pancreas causing destruction of pancreatic exocrine cells and subsequently release of trypsinogen or tryptase and subsequent damage of the body, which we'll go into in a second. So that usually small gallstone only stays there for a minute, causes acute pancreatitis, and is subsequently passed. It usually does not stick around to cause obstructive jaundice. Usually, sometimes it absolutely can, and we'll get to that. And once we get to treatment of acute pancreatitis, other things that you want to think about is going to be increased triglycerides. So increased triglycerides can cause damage to the pancreas and subsequent pancreatitis. Most commonly, you'll see this with someone with commonly diabetes. They'll be in if they have diabetes, they'll have insulin resistance. They won't have activation of lipoprotein lipase, so LPL, and they won't have subsequent intracellular movement of the triglycerides. The triglycerides will basically be increased and can cause pancreatic toxicity and subsequently pancreatitis. Lastly, another big ones would be calcium as well. So not common, but very easily to rule out, and something I have seen before in a patient that had cancer, subsequent metastatic cancer, and hypercalcemia malignancy came in with acute pancreatitis. And definitely something to work up. If you have someone with hypercalcemia that has epigastric pain, you always really want to check a lipase in these patients. So those are some of the major causes of pancreatitis. Lastly is going to be drugs. And I like to remember the drug causes of pancreatitis by really the patient, the type of patient who gets pancreatitis, right? So some of the patients that with patient risk factors that get pancreatitis or certain diseases would be heart failure patients, right? And the big cause of pancreatitis in this patient is really going to be diuretics. Diuretics can really cause dehydration and subsequently thickening of your pancreatic fluid. And that thickening of the pancreatic fluid can cause a blockage, which can then cause acute pancreatitis. 2 would be HIV patients. Not only do some of the protease inhibitors cause pancreatitis, but even long-term PCP prophylaxis. So if they, let's say, have their CD4 count consistently less than 200, they might need either a sulfa drug like Bactrim, or they might need, if they can't tolerate that, pentamidine. These also cause pancreatitis as well. 3, be patients with autoimmune disease. So a big major cause, and one that I have seen in the ICU of acute pancreatitis, was a patient with Still's disease, was on chronic steroids for a long time, and those chronic glucocorticoids gave this patient pancreatitis as well. Other meds, 5-ASA, I think can cause acute pancreatitis as well. Lastly, just patients on patients that have epilepsy. So a big one would be valproate. Can absolutely cause pancreatitis as well. The patients not only are they concerned for getting things like Stevens-Johnson syndrome, in some cases, these patients can even get SIADH, but, you do need to worry about valproate and causing pancreatitis. And last one would be diabetics or weight loss. And the big one here would be those GLP-1 agonists, which are commonly used for weight loss, as well as commonly used for patients with diabetes, especially patients have diabetes and they have CAD, history of CAD, and MIs, it decreases morbidity and mortality. So those are really, there's other things, random things, vasculitis, can cause pancreatitis shock, can cause pancreatitis trauma, obviously, scorpion bites, yada, yada. These are really the main causes that you're going to see most commonly in the hospital. So going back to our workup of pancreatitis, what do you always work up? Well, you always want to do, obviously, an H&P. You want to see, and a med check. You want to see which type of meds that the patient's on. You want to see if they drink alcohol. You want to see if they had any trauma that incited this. Next one that you'll want to do is going to be an ultrasound. So if you do an ultrasound, you don't find another reason for pancreatitis, and you see, here's your gallbladder here, and subsequently here is gallstones. You know that they're helpful to know that their gallstone is not polyps because you can see shadowing behind them. If you have no other cause of pancreatitis and you see gallstones there, you can really make that the diagnosis of gallstone pancreatitis as well. Lastly, it's going to be check triglycerides. Usually I just check a lipid panel just to rule this out. LFTs. And LFTs can be helpful to see, maybe if they drink alcohol, do they have alcoholic hepatitis concurrently. But the other thing that's going to be helpful is that ALT is very elevated. That really actually increases your risk of gallstone pancreatitis. And the reason why is it means that probably that gallstone got stuck in that common bile duct common bile duct and pancreatic duct. That's caused subsequent congestion, which then subsequently caused a little bit of liver damage, right? So checking an ALT is going to be helpful too to help you diagnose biliary pancreatitis before you actually have an ultrasound that shows gallstones. And lastly, one thing you really don't want to miss for workup would be check on calcium. So on your admission, these are definitely the things that you really want to check for every patient, though, not every, this catches the majority of cases of pancreatitis, but not all of them. So, always do your due diligence to work up. So that's your workup for acute pancreatitis here. But you really always initiate that workup after you make the diagnosis of acute pancreatitis. Okay, so next one, Paul, is did you mix that 19 GI question? 16, so give yourself some time to do that, and then we will go over treatment of acute pancreatitis. So, all right, subsequently, so treatment and prognosis of acute pancreatitis. So prognostication is going to be important, though there had been multiple clinical scoring systems for acute pancreatitis, though kind of been shown that serves on admission and at 48 hours, as well as when these patients get acute pancreatitis, releases tryptase, subsequently vascular damage, subsequently capillary leak, and then that subsequent capillary leak increases their hematocrit, increases their BUN. If you have increased hematocrit, increased BUN from that capillary leak, that is a poor prognostic factor as well. So these SIRS and increased hematocrit and BUN really perform just as well as other scoring system. So fluids, what type of fluids? So this had been a little bit discussed for a long period of time of what fluids are going to be the best for treatment of acute pancreatitis. I will say with patients without end organ dysfunction, it's very evidence-based that we do more of a moderate fluid resuscitation. So in those patients, if you think that their volume is down, you think they're hypovolemic, you would give them 10 cc's per kg. And then for all patients, you would do 1.5 cc's kg per hour. Now, usually you're going to do LR isotonic fluids that are more similar to blood plasma in terms of bicarbonate chloride, or much better. So LR is good. Just remember, you may not want to use LR in someone that has pancreatitis due to hypercalcemia, as LR has calcium in it. Patients, so if no end organ dysfunction, so people with mild, moderate pancreatitis, this would be your go-to. I think when people start getting some of the other manifestations of pancreatitis and end organ dysfunction, those things like AKI, things like ARDS, they might have to be a little bit more individualized. But in patients who do not have end organ dysfunction, it's pretty evidence-based due to the waterfall trial to give these patients 10 cc's per kg if they're hypovolemic, then subsequently 1.5 cc's per kg an hour. So nutrition, this had been changed within the last, 10, 20 years. It used to be thought that withhold nutrition is, you think that giving someone food will then subsequently activate the pancreas and subsequently release the pancreatic enzymes. Fortunately, there's been studies on this, and it's been shown that you really want enteral nutrition as soon as possible. So as soon as the patient can tolerate oral, you give them oral. If they're not able to tolerate oral, then you really want to put in like an NG tube for feeding within 72 hours. And the reason why, or at least the thought of the reason why, is that patients that, let's say, are, where is it again? Say patients that are, so here's your GI tract, patients that are NPO for a long period of time, so they're not getting any oral food, then you kind of have a bit of atrophy of your epithelial cells in your GI tract, and that actually increases risk for bacterial translocation. The oral nutrition inhibits subsequent GI atrophy, which prevents subsequently bacterial translocation, which has been shown to decrease subsequent bacteremia in these patients, and then decrease morbidity as well. So that's the thought process of why we do that. So oral as soon as possible. If they cannot take oral, you want to put an NG tube in these patients within 72 hours as well. That would be our enteral nutrition. Lastly is, always remember analgesia. These patients, relatively low threshold to do a PCA pump. And the other ones, so a couple more. Remember, LR is probably the best for IV, unless they have hypercalcemia. A couple more. So say they have gallstone pancreatitis. Ask yourself now, what does everyone with gallstone pancreatitis need for treatment of, or actually to decrease subsequent recurrence of their gallstone pancreatitis? So ask that question to yourself. And the answer is all these patients are really going to need a cholecystectomy to decrease subsequent recurrence. And it's been shown that doing a cholecystectomy before discharge is more helpful to really decrease subsequent recurrence of these patients by removing the inciting incident of why they got pancreatitis in the first place. So it's a little bit more difficult, and I think, we need to take out the stone. But like I went over, most of these patients already have the stone out by the time that they come in. The stone had been subsequently at that pancreatic duct for a moment and then subsequently passes. The only time you would ever do something like an ERCP, only really time you would do an ERCP would be if you think that there is a subsequent retained stone right now. So say these patients have, persistent elevation of their LFTs, persistent elevated bilies, especially that bilies up plate 4. So if you think there's subsequent concomitant choledocholithiasis, or if you think that there's subsequent cholangitis, those are the patients that you're going to need to do ERCP for. But it is really not routine for patients with acute pancreatitis secondary to biliary disease, as that stone is usually already passed. Let me get this out. Right. Do I remove this? No. All right. Well, I don't know how to remove that right now. So this one says down here, if elevation of triglycerides. So if you do have elevation of triglycerides, we kind of talked about earlier, hypertriglyceridemia usually is secondary to diabetes, usually because of insulin resistance. They don't have activation of lipoprotein lipase, which doesn't shunt triglycerides from the blood into the cells. So how can you really get over this? Activate lipoprotein lipase and shunt that. The way that you really usually going to do it, and the first line treatment for hypertriglyceridemia is going to be insulin. So insulin is going to be your first go-to. I will say, and I won't get into when you do this, but plus minus apheresis. If patients are super, super sick, if they're in the ICU, if they have severely elevated levels, sometimes this is an option, but not something to be tested on, because I think the evidence is somewhat mixed on this. Long-term would be control if they have it secondary to diabetes, control their diabetes, and the long-term control of triglycerides. If they have an indication for a statin, you would do that. If not, you would end up giving these patients a fibrate. And you may need to add on a fibrate as well, just to get the triglycerides low enough so they don't have an increased risk of developing acute pancreatitis secondary to that. So that kind of goes into treatment prognosis of acute pancreatitis. We'll review this a little bit at the end. All right, so pause and do mix up 19 GI question 32. All right, so there is 2 major times of increased mortality secondary to acute pancreatitis. So when people first have acute pancreatitis, they have activation of lipase, tryptase, they have release of these enzymes that usually digest your food into the bloodstream. They can, as I was talking about earlier, they can get capillary leak, so they can have decreased intravascular intravascular fluids, which is why giving these patients fluids is so important, because not only can they get organ damage from inflammation, but they actually can also get organ damage secondary to ischemia, secondary to capillary leak, and decrease intravascular fluid pressure, intravascular fluid volume, which is why fluids is such an important component of treatment of acute pancreatitis. And during that time, those tryptase and lipase can go to your alveoli, causing diffuse alveolar damage, ARDS. They can they can go to your kidneys, subsequently directly damaging the kidneys or injuring the kidneys by hypovolemia, with first primary azotemia and then secondary the ischemic ATM. So that's the first part of increased mortality with pancreatitis. The second, especially with patients with necrosis or severe pancreatitis, is long-term manifestations, and this is more subsequent infection, symptoms from pancreatic collections, and basically pressing on subsequent structures within the abdomen. So going over the pancreatic collections, these are subsequently described by time course. So less than 4 weeks and greater than 4 weeks is going to be our cutoff for time course. So your first one, and then this is basically the pancreas. You can see that it's edematous. You can see that there's inflammation going on. Right here is going to be fluid collections that's in this arrow around the pancreas, and this is called acute pancreatic fluid collections. Now, over a long time, these can get mature. They can develop a fibrous capsule, inflammatory fibrous capsule around it. And after 4 weeks, if these persist, this is going to be called a pancreatic pseudocyst. Now, collections that come from necrosis, if less than 4 weeks, you can kind of see the pancreas here, a little bit of the outline here, here. This is probably the splenic vein right here, and then here in this dark area, you can see necrosis. So acutely, this dark area is going to be called acute necrotic collections. And just like peripancreatic fluid collections going to pancreatic pseudocyst, over a long period of time, these can encapsulate, mature, and be called walled-off necrosis. Subsequently, can be hard, from my understanding, to determine. And then here you kind of see this picture of basically like walled-off necrosis here, maybe a bit right here as well. The problems with these is they can cause obstruction within the GI tract. So they can cause press on the stomach. They can cause food intolerance, early satiety. They can press on the biliary tract, causing jaundice. Or they can cause symptoms of acute, really severe abdominal pain. So indications for drainage would be really any of those symptoms that I just mentioned, or obviously if you have an infection, to get source control. If you have an infection of the pancreatic pseudocyst or walled-off necrosis, it's very important that you intervene and drain these infections. Treatment of infected pancreatic collections. Remember, this is abdominal infections, so you really need to think about mostly gram-negatives plus anaerobes, right? So, the options really here, if you don't want pseudomental coverage, ceftriaxone and metronidazole. Remember, ceftriaxone doesn't cover anaerobes, and metronidazole does. But mostly because there is good pancreatic penetration. One of the meds that you use would be meropenem, or another one that you can consider using would be Zosyn. For treatment of these collections, you would want to aspirate, though if you are able to, and if these patients are controlled by just antibiotics, a lot of times aspirate for cultures. But if they are controlled with antibiotics, drainage, you usually want to wait until it's mature if you can. And then drainage once it's mature, if it is a pseudocyst, then you can just basically take a needle, put it into, and drain that. So pseudocystic, you can do aspiration for fluid drainage. A little bit more harder with patients with acute necrotic, walled-off necrosis. These patients will need debridement. One of the newer management for debridement that I've seen here is going to be a cyst gastrostomy with debridement, right? So the way that this does this is an endoscopist goes in, here's the walled-off necrosis, and they can make stents basically from the GI tract to the walled-off necrosis, and then subsequently go in, the endoscopist, and basically debride this out, and then as it gets debrided, it gets dumped back into the GI tract, and that necrotic fluid gets subsequently digested. So cyst gastrostomy with necrosectomy is one of the ways that you can kind of control walled-off necrosis when it's subsequently infected as well. And something that I've seen before done inpatient and inpatient where I did residency. All right. So perfect. So these are pancreatic fluid collections. All right, so calls to except 19, GI question 93. We'll subsequently get to that. All right, so this goes into a little bit of chronic pancreatitis. So chronic pancreatitis is usually someone who has recurrent pancreatitis. The major risk factors for this is going to be alcohol use, obviously. Smoking is a risk factor. Sometimes people do have family histories of pancreatitis. Things that have been shown to be correlated to that is like SMIC5 mutations, even patients with cystic fibrosis. So diagnosis of acute pancreatitis, I'm not going to go into that diagnostic criteria, but it really has a patient with symptoms. Now remember, if these patients have an atrophic pancreas, they've burned through a lot of their pancreatic exocrine cells. So they may not always have lipase when they're having acute pancreatitis flares. So something to remember for sure. And the diagnosis of chronic pancreatitis really is going to be helpful to do imaging. The two imaging modalities that you can see here is going to be an MRCP. MRCP may be a little bit less sensitive for chronic pancreatitis, but is relatively more specific. And things you might see would be, here you may see ductal dilation of the pancreatic duct. You may see pancreatic atrophy around it. You may see pancreatic calcification as well, which you can see right here. All signs and symptoms of chronic pancreatitis. Another one you can do is going to be EUS. EUS is a little bit, I would say, more sensitive, but less specific. Obviously, there's operator variability to this as well. So here's your endoscope here, and you're looking at the pancreas. You can see that the pancreas is duct is dilated right here, right there, as well as you can see some ectatic calcifications and maybe fibrosis within the pancreas itself. Here you can also do a biopsy as well to see if there's any fibrosis under a microscope. So workup for chronic pancreatitis. Well, you've already done one of them. You would need an MRCP usually, and that's really looking for the cause of acute pancreatitis. So could this patient have a long-term stricture, or maybe a mass lesion like an IPMN, intrapapillary ductal neoplasm. I'll get to this one in a little bit. Or like an IPMN that's causing obstruction of the duct and acute pancreatitis. So not only is this good for diagnosis, it's really good for looking up the causes as well. If not checked before, check these patients for triglycerides. Other things you want to think about, I would say, plus, maybe you don't need to work on this in a patient that has chronic recurrent alcoholic pancreatitis, that's a smoker. But, maybe if you have a patient that you're not sure why, maybe they're younger, 35 years old, you can do a genetic workup. And I would say plus minus autoimmune workup. For this one specifically for IgG4 disease, things that might clue you in, these patients will have a very large, like they always called like sausage pancreas with a very edematous pancreas. They also have lesions of the bile duct sometimes that looks a little bit like primary sclerosing cholangitis, so they might have strictures of their common bile duct. They might have some constitutional symptoms chronically. They might have evidence of IgG4 disease elsewhere, like retroorbital tumors, or enlargement of the parotid, or lingual glands, or retroperitoneal fibrosis, rectal styroiditis. You might have other manifestations too. So you don't always need to think about working up for IgG4, but if you do, you can check a serum IgG4, or you can subsequently do a biopsy and stain for IgG4 as well. But the ones you always want to check for is going to be MRCP and triglycerides. And now the big thing is how do you treat these patients? And it's high risk for them to develop opioid abuse disorder over a long period of time because of subsequent pain. So the big interventions that you want to do. So number one, it's going to be lifestyle. So control the risk factors, right? Stop smoking. Stop alcohol. Small meals can be helpful too. Maybe you don't stimulate the pancreas as much with smaller meals, and also ensure that they don't get dehydrated. Dehydration can actually spur pancreatic inflammation and chronic pancreatitis flares as well. So ensuring that the patient's hydrated. Next is going to be look to see if they have any malabsorptive disorders, foul, greasy, floating stools after the patient eats. It might be secondary to an exocrine deficiency, right? They're not getting as much lipase, tryptase here, so they're not breaking down their food, they're not breaking down fat, they're subsequently getting chronic diarrhea. So if they do have diarrhea or malabsorption, these patients would do well with pancreatic enzyme replacement. Used to think that it actually helped with the pain too, but it's been shown that the only indication now is really for diarrhea or malabsorption for pancreatic enzyme replacement. It doesn't help too much with the pain. Lastly is going to be pain. Now you want to do is conservative and then kind of go from there. So you want to start with things like Tylenol. You want to think about NSAIDs, and then you might need to go to even treatment of neuropathic pain, as you do have your celiac plexus here that innervates the pancreas and maybe shutting down any nerve transmission there, which you can do with things like gabapentin, pregabalin, or increasing the patient's norepinephrine. Now think about anytime you get in a fight, you increase norepinephrine, that decreases your pain, so that can help with pain tolerance and things like TCAs, SNRI. Lastly, if all this doesn't work, that's kind of when you go to invasive management. And now invasive management does differ a little bit whether the patient has a dilated duct or a non-dilated duct. So if the dilated duct, that means that there's a blockage here, right? So say there's a blockage here and you get the dilation of duct behind it, the pancreatic juices can't escape, and since they can't escape, they're causing chronic pancreatitis flares. So if you do have a dilated duct, you really want to go in with a scope and open that duct plus minus. Not sure if you stent it, but you definitely want to open the duct through endoscopic means. If the duct is not dilated, it's a little bit more difficult. Things that you can do, it would be a celiac plexus block. Now that doesn't work for the longest time, unfortunately, so it's not a permanent control. Or sometimes if they're really, really severe, you might need surgery and something, they may actually resect the pancreas, or even resect parts of the pancreas. I was present once for a surgery where I think a lot of the atrophic pancreas was in the distal, and they actually did a distal pancreatectomy. So sometimes removal of the pancreas is your last option that's needed. All right, so that's your conservative management, invasive management of chronic pancreatitis. This can be very, very difficult. Recurrent hospitalizations from subsequently pancreatitis flares and subsequent severe unrelenting pain. And a lot of times these patients do need long-term opioids. They may be on long-term opioids, but problem with that is long-term allodynia and tolerance to opioids and decreased efficiency of their use. So something that you would try your best to prevent. All right. Last thing I didn't mention here, sometimes this might be a little bit more advanced and not needed, but secretin enhanced MRCP can sometimes be helpful if you really have a high suspicion for chronic pancreatitis, but your first line MRI, MRCPs, EUS has not shown what you're expected. All right. So do next step 19, question 69. So this one is a bit to cystic neoplasms of the pancreas. So there's basically two general types of cystic neoplasm pancreas. Some are mucin producing, some are non-mucin producing. Sometimes the radiologist can tell by features that we won't go too much into, what type of cystic neoplasm it is in the pancreas, and can give you subsequently guidelines from that. But a lot of times it can be difficult, so you may need to pursue other imaging modalities, sometimes aspiration. But anyway, without further ado, the two types of mucin producing would be IPMN, the intraductal papillary mucinous neoplasm, versus mucinous cystic neoplasm. If you do find this, this is a moderate to high risk pancreatic lesion that can subsequently does somewhat commonly turn into pancreatic cancer. IPMN is one of the more common test questions you're going to get. And the risk of this lesion depends on where the IPMN is and depends on the high-risk features of the IPMN. This one would be a main duct IPMN. So it's blocking the main duct. You can see that there is dilation, blockage and dilation of the pancreatic duct behind it. This is a very high-risk lesion. It has increased ability to turn into pancreatic cancer. Less high risk, so as you can see here, coming off of the side duct, not blocking the main duct, would be a branch duct IPMN. This is low risk, usually more on the low risk side, unless they have high risk features. And the high risk features that you really want to look at would be large lesions, especially getting bigger than like 1.5 centimeters. Large lesions, solid components to these cystic lesions, symptoms, complications to these lesions, duct dilation, and family history. Next is non-mucin producing. First one we'll go into is this one here. Now this is your really only non-risk lesion, since it's serous cystic tumor, or also serous cystadenoma, also called cystadenoma. If you have the imaging, it's totally consistent with cystadenoma. The radiologist is sure that you really don't need to worry too much. You don't need to follow this up with imaging. You can just say it's a no-risk lesion. The other one is going to be a solid pseudopapillary neoplasm. This is risky. This is commonly can transition. It's commonly preneoplastic. So management, really wish I did. So management would be for high risk, really high risk lesions. So let's say main duct, IPMN, mucinous cystic neoplasm, or solid pseudopapillary neoplasms. If it's high risk, you really want to resect. In some cases, say moderate risk, not sure. Sometimes you can aspirate, so maybe like a lesion that you're not sure what it is, greater than 1.5 centimeters, you can aspirate, though you need to know it's not going to be totally sensitive and specific. Low risk lesions, let's say like a branch duct IPMN, these you can follow with imaging, or any lesion that's a low risk or more that you're not going to resect, you can follow up with imaging. Imaging modality you're going to want to use is going to be an MRCP, MRI MRCP. So your serous cystic or serous cystadenoma, these ones, there's no risk. So if you're really sure that this is what it is from radiology, from an MRCP, all these lesions, the best way to categorize them is going to be an MRCP. If you're really sure that that's what it is, and I'll write that in. Lastly, it would be an MRCP. Just make sure if they haven't had it yet, MRCP for all. To further classify these lesions. If it really truly is that, you actually don't need to follow these. But anything else, anything that's low risk or any low risk or above that, you're not going to do. you're not going to do a resection on. You really want to follow that up with serial MRIs to see if it's growth or if there's any stable, or if it's stable. All right, and this is, I think, maybe our last question to do. Except 19 GI question 13. And this is a review of your MEN. So there's a lot of different ways to do MEN. I think about, MEN1, I think about 3 Ps. So 3 Ps. MEN2A, I think about 2 Ps and an M. And MEN2B, I think about 1 P and 2 Ms. And then there's a lot of overlap here as well. So MEN1, I think that the MEN, this is kind of a disorder that you increase your risk for neoplasms, basically from genetic mutations that dysfunction of tumor suppressor genes. So the things that you can get in these cases, one would be pituitary adenoma. The second one, and please review the pathophysiology of why MENs cause cancer. I kind of just made that one up. Don't quote me on it. The second common tissue proliferation that you're going to get for these patients is pancreatic neuroendocrine tumors. And the one that's going to be shared between MEN1 and MEN2A is going to be parathyroid hyperplasia. So same thing, parathyroid hyperplasia you get with MEN2A. And MEN2A you also get PHEOs. PHEOs also shared with MEN2B. And the last thing you're going to get here is medullary thyroid carcinoma. I'm putting it in red because I couldn't see my marker anymore. And same thing here, medullary thyroid carcinoma. MEN2B would be pheochromocytoma, medullary thyroid carcinoma, and lastly, mucosal neuromas. Some people also put in here Marfanoid hepatitis, so Marfan syndrome. All right, so those are your MENs. This is the way I kind of remember it. I think of 3 Ps. One of those Ps is shared between MEN1 and MEN2A. And then I think 2 Ps and an M. And then I think 1 P and 2 Ms. So you kind of get more Ms as you go down. With MEN2A, you have 1 M, and by MEN2B, you have 2 Ms. And a lot of these Ps are shared. So lastly, pancreatic neuroendocrine tumors. Most of these, this is actually where I think Steve Jobs died from. Most of these are going to be non-functional, but every once in a while, about 20% of patients, you can have a pancreatic neuroendocrine tumor that is going to be functional, and they can kind of secrete different hormones that help the GI tract function. So the hormones we're going to talk to about let's go first. These patients, this one increase of this hormone is basically almost the same physiology of cholera. Increased cyclic AMP in the GI tract. These patients have an increased intestinal fluid and electrolytes. So these patients can get diarrhea, really large volume, non-bloody or continuous secretory diarrhea, which means it's completely ongoing, and that diarrhea can give them dehydration. They also may have acrocardia, decreased acid in their stomach. This can lead to a lot of the same manifestations of PPI, increased risk of infections, increased risk of hypomagnesemia, osteoporosis, B12 deficiency. And this one is a VIP coma. So say you have chronic secretory diarrhea, you are not sure of the cause. This is a common time. Well, not a common time. Really rule everything out. You can check VIP levels. So they will have increased VIP levels. And treatment, really, for all these, is going to be resection. if they're symptomatic, right? You can't resect it, those patients, you might do things like debulking, chemo, and to decrease really any hormone in the GI tract, giving these somatostatin analogs like octreotide can help. The first line really is going to be resection and VIP hormone. You're going to diagnose with VIP levels. If you are concerned, let's say if a patient comes in chronic secretory diarrhea, workup has been completely negative, you check the VIP level, it's elevated or concern for a neuroendocrine tumor, you do want to do localization. And your first line for localization is really going to be an MRI or a CT of the abdomen. Sometimes they can be small, and if you have a very high suspicion and you think there's a small one, the next thing you can do is EUS, or you can kind of do like somatostatin scan-based modality. So somatostatin scintigraphy is one of them, or you can do a PET scan that looks for octreotide uptake as well. So those are going to kind of be your second line if you have a high suspicion and you think it's too small for an MRI or CT to pick up. Next is going to be this patient. So this patient, let's say, has really severe recurrent epigastric pain, especially every time this patient eats, and you undergo an EGD, and you see that there's all these ulcerations in the duodenum. This hormone is going to be gastrin. So gastrin secreted into the GI tract, subsequently activates the parietal cells to increase H secretion, which gets increase your acid within the which increases acid within your stomach, which stomach and duodenum subsequently cause ulceration and abdominal pain. Also, if that increased acids in the duodenum can even cause inactivation of pancreatic enzymes, so these patients can get a malabsorptive diarrhea as well, so it's part of that differential too. So diagnosis of this would be increased gastrin levels, but remember they need to have a pH less than 2, and they need to be off of PPI. So PPI will decrease acid secretion by the parietal cells, which will subsequently decrease negative feedback on gastrin, and gastrin will be elevated on people with PPI. So you really do have increased gastrin with pH less than 2 and off the PPI. Treatment here is once again resection. If you cannot resect, things like debulking, chemo, and octreotide, similar to VIP hormone, can be helpful. Next one, so this patient, let's say, comes in with wheezing, has this maculopapular rash, has elevated neck veins with CV waves, and has chronic diarrhea. And you do, let's say, point of care ultrasound or an echo, and you see this. What we're looking at here is your LV, RV. See your mitral valve here, and then here you can see, take a look at the tricuspid valve. So there's complete retraction of that tricuspid valve, secondary to increased serotonin levels causing fibrosis. And the diagnosis of this is going to be carcinoid syndrome. Diagnosis would rely on increased metabolites of serotonin to increase 5-HIAA, and you can kind of see that these patients may get a maculopapular rash, may get tricuspid, severe tricuspid regurgitation, fibrosis of the tricuspid valve. Not surprising, again, treatment is the same. It's going to be resect. If you cannot resect, debulking, octreotide, chemo can still be helpful. Another one you may think about, patient comes into the hospital, they have recurrent episodes, they don't have any past medical history, let's say. They have recurring episodes of headache, shakiness, dizziness, blurred vision, sweating, extreme hunger, and being really upset and really anxious during these episodes. The diagnosis here would be insulinoma. And the diagnosis of insulinoma really depends on a patient with low glucose, and then they also have increased insulin and C-peptide. One thing you want to rule out here is the sulfonylurea strain. Sulfonylurea use is really the only thing that will cause endogenous insulin secretion, causing elevation in insulin and C-peptide while patients hypoglycemia. So you do want to rule that out, especially if there's any, in all cases, especially if there's any concern for the patient, using that medication surreptitiously. Treatment for this, no surprise, resection. The only one difference is that if you can't resect to control symptoms here, instead of using octreotide, you'll use diazoxide. And the way that diazoxide works here is that usually insulin secretion of the beta cells happens because the potassium channel is closed. Once the potassium channel flows, calcium influx into the pancreatic beta cells, subsequently releasing insulin. Diazoxide stops those potassium channels and the beta cells from closing, subsequently inhibiting release of insulin, subsequently preventing or help prevent these episodes of symptomatic hypoglycemia with insulinoma. Lastly, these patients, this is a catabolic hormone that can be sometimes secreted. These patients may have cachexia. They may actually get, as it's a catabolic hormone, increases glycogenolysis, gluconeogenesis. These patients may get increased risk for diabetes, and they may have this necrotic skin rash, which is necrolytic migratory erythema. This one is glucagonoma. This rash is thought to be due to the catabolic effects of glucagon and the inability of amino acids to get into the keratinocytes and subsequent keratinocyte death with necrosis of the skin causing necrolytic migratory erythema. Diagnosis here, elevation of glucagon. Obviously, you might need to do localization as well. And then treatment for these patients, once again, resection, can't resect, once again, chemo, debulking, octreotide, anything really to decrease symptomatic secretion of these hormones. So these are your neuroendocrine tumors that you see most likely in the pancreas. Remember, for localization, let's say you have a patient with chronic secretory diarrhea, and you have an elevated VIP level or gastrin level or a carcinoid level. You want to localize first with MRI or CT of the abdomen. If that's negative, when you still have a high clinical suspicion, you could have EUS or some somatostatin uptake-based scan, like somatostatin scintigraphy or an octreotide-labeled PET scan. Insulinomas, remember, the only ones that you don't really use octreotide for dramatic control, you would use diazoxide if you can't fully resect these. And that is it. Review. We'll just keep this at the end so you guys can review this if needed. This is our diagnosis, workup, and treatment for acute pancreatitis. Remember, not everyone with gallstone pancreatitis needs an ERCP, really only if you think that they have cholangitis or choledochlothiasis, which might clue you in for an enlarged common bile duct for Christian nephritis. Remember the pancreatic fluid collections. You have acute peripancreatic fluid collections, acute necrotic collections. When these mature, the fluid collections may turn into a pseudocyst, and the acute necrotic collections might turn into wall-off necrosis. Only treat these and drain these if there's symptoms of concern or infection. Antibiotics, if you think there's an infected pancreatic fluid collection, will be meropenem, plus aspiration with culture. Drainage, we really want to wait until it's encapsulated so you can really drain the whole cyst or debride the whole walled-off necrosis, and it won't subsequently leak out right afterwards. So needle, if you think if it's pseudocyst or debridement with walled-off necrosis, which sometimes you can do by cyst gastrostomy and nephrectomy, which is an endoscopic procedure, which is relatively new. Diagnosis of chronic pancreatitis. Here's some of the histology of a normal pancreas here. Your exocrine cells, some of your pancreatic ducts here, and here's that replacement with fibrosis, which remember, these patients can get exocrine dysfunction, which can give them malabsorptive diarrhea or endocrine dysfunction. These patients have a high risk for diabetes, especially brittle diabetes, because they have not only low glucagon, but low insulin. So it's hard for them to deal with hypoglycemia and hypoglycemia, which is why we call them brittle and why they can commonly get overdosed on insulin or pretty severely underdosed, as they really don't have any good compensatory mechanisms. Workup for chronic pancreatitis via MRCP, triglycerides, its suspicion we went over genetic causes or autoimmune pancreatitis like IgG4. And remember the stepwise management: stop alcohol, stop tobacco, small meals, hydrate, analgesics. And third, if malabsorptive, diarrhea, you want to do pancreatic enzyme. For invasive management, really only passive refractory severe pain. If the duct's obstructed, you do dilation or lithotripsy. If no duct dilation, you might do a celiac nerve block for surgery. Remember, that's invasive, difficult. You really want to try all the other things first. Cystic neoplasms. Remember MRCP for all these patients. Resect them. MRCP is going to be best to see what kind of characteristics of these lesions to see this risk for neoplastic conversion. Resect for high-risk patients. Aspirate if moderate risk, and that might help you a little bit more whether they need to resect or whether they need to be followed with imaging, which you do for low-risk patients or patients you may not be resecting. And you'll follow with MRCP. I think it's still somewhat exactly how long you need to wait until serial imaging is something you can look up and not something you'll be commonly tested on for the exact timing. And lastly, this is our last image of all of your pancreatic neuroendocrine tumors. Remember, only 20% of these are actually symptomatic. If you are concerned for symptomatic neuroendocrine tumor, first line CT or MRI of abdomen. If you still have a high suspicion for a small lesion, you might think about EUS, trace high cytography, or somatostatin-based PET scan. So these kind of, basically what I was talking earlier, these are tagging somatostatin or octreotide, which is then subsequently brought up by the cancer. So if you tag it, you can kind of see where if there's any cancer located in the pancreas. And that's it.